Welcome to the Explore Global Health podcast. I'm Dr. Rob Murphy, Executive Director of the Havey Institute for Global Health here at Northwestern University Feinberg School of Medicine. Long COVID syndrome, or long COVID, also known as the post-acute sequelae of COVID-19, is being studied throughout the United States, Europe, and Asia. But there have been less than 5 studies per continent on this condition in Africa, Oceania, and South America. So it's been much more heavily studied in the higher income countries and in the West. Today's guest is working to change that. Dr. Gina Perez-Giraldo is a second-year neuro-immunology fellow and global neurology fellow here at Northwestern University. And she's been working on establishing neuro-COVID-19 programs in Nigeria and in Colombia, and collecting data to help characterize this debilitating syndrome around the world. She joins me today to talk about this work and the path she has carved out in global health. Gina, welcome to the podcast.
Yeah, of course. And thank you, Dr. Murphy, and thank you for having me.
You began your career in global health in your home country of Colombia as a medical student. Can you tell me, what was your motivation to study medicine? And then what was your motivation to come to the United States for further training?
Well, my motivation to study medicine was a little different to what you typically hear. In Colombia, South America in general, we don't do college. Like we go straight from high school to whatever you want to do as a career. So when now I was supposed to be a lawyer, because my parents are both lawyers. But at the end of high school, I saw this TV show talking about neurophilosophy and looking at trying to search the soul through the nervous system. And that's when I was like, oh, that's really cool. I decided that I wanted to study medicine to eventually learn about the nervous system. And definitely was very different to what you hear why people go into medicine. But as I started medical school and did my electives in neurology, I confirmed that that was the right decision. And here I am.
What made you come to the United States for further training? How did that happen?
I always knew that I wanted to do my training somewhere else. I had a great life in Colombia, like all my family is there and everything was great. I have no complaints. I just always knew that I wanted to get out of my comfort zone. I feel like every time that you get out of your comfort zone, do something different, you grow, you evolve. So I always knew that I wanted to do that I wanted to train somewhere else. My medical school had a strong affiliation with the University of San Antonio, the Texas in San Antonio. So I did an internship there when I was in medical school, and I decided to do it, to just go to a new place, new language.
How long were you in San Antonio?
I was there for 6 months. Okay. I did 1 semester of medical school there. So I thought it would be fun to just do something completely different, and decided to start all the process to do my residency here. And that's how I ended up here.
So how did you end up at Northwestern?
I did my residency first at the University of Oklahoma. Those were my first 4 years of training. Once I did neurology, I got very interested in autoimmune diseases and neuroinfectious diseases. And Northwestern specifically has a great neuro-immunology program with the addition of having a neuroinfectious diseases program too. So I applied and here I am.
Have you always wanted to focus on global health as part of your training, or was that something that evolved later, or did it start early in medical school or even before medical school?
I think that that's something that started early in medical school. That's part of the reason why I also knew that I wanted to do my training somewhere else. I wanted to see other places, see how the healthcare systems were in different places. And I think that being from a third world country and being exposed and seeing patients that belong to underserved areas, like knowing that there's limited access to certain resources, makes you have some certain sensitivity to it. And specifically once you transition from that environment to a wealthy country like the US that has such different access to medical care, such different access to just like diagnostics and treatments. And you know that that is not the case everywhere in the world. And you know that there's not that access to research in other places. I think that that's what got me specifically motivated to do global health. I'm in a position now that I'm working here in the US. I think it's great to get back to not only my country, but other places that don't have such access to healthcare and research, and hopefully help decrease that gap that definitely exists.
You completed your residency training in neurology at the University of Oklahoma, like you said, and then you started your neuro-immunology training at Northwestern in July 2021 during the COVID pandemic. Northwestern Fellowship focuses on multiple sclerosis and neuroimmunology. But then during the pandemic, there was this pivot and you started caring for patients with long COVID and publishing studies about these patients. And that became a big part of the fellowship. Can you elaborate a little bit more on that? You really adapted your training to accommodate what was going on all around you and all around the world.
Once I arrived in July 2021, the Dr. Koralnik, he had already started the clinic. Dr. Koralnik has had like the experience in neuro-HIV in the past, and then they started seeing patients that were just consulting in the clinic because even though they didn't have severe COVID infection, they were having this persistent lingering neurological symptoms. So he created the clinic and gave the opportunity to the fellow to be involved. That's how it all got started. Then he also opened the doors because he was doing research already. The group already had publications before I joined the team, but he opened the doors for me to be part of his research projects. And that's when I joined. And I've been working now for over a year. It's going to be almost 2 years. We have a weekly clinic in which we only see neuro-ID, but we mostly see neuro-COVID patients.
Yeah, and you mentioned Dr. Igor Koralnik in the pretty well-known clinic that he started about long-term neurologic complications of COVID. Dr. Koralnik is the program director of our global health program in neurology. And so he's been with us since the beginning, which was only 2019, actually, really just the year before the pandemic started. Can you give us a little information about the overall prevalence of long COVID in the United States, and particularly the proportion of people that have neurologic symptoms and what kind of symptoms they have?
In the United States, about 30% of the COVID-19 survivors will have persistent lingering symptoms. So of all the millions of people that have been infected in the US, 30% of those will have some lingering symptoms, which is a pretty high number. And then we know now that neurological long COVID or neurological sequelae of COVID-19, it's now the third leading cause of consultation to see a neurologist in the United States. Like this was declared last year by the president of the American Academy of Neurology. So it became a very prevalent condition and a very common cause of consultation. The most common neurological symptom is what people call brain fog. Brain fog means different things for different people. Some people describe brain fog and they mean having memory problems. Other people is attention problems, or other people just feel like they're in a daze, that they feel like they are out of it. And that's the most common. We have seen in our research that over 80% of the patients that come to see us in our clinic report some degree of brain fog. Other common symptoms that we see are headaches. About 70% of the patients describe that they have headaches. Patients say that they have depression, anxiety as well, related to either people that never had depression and anxiety, and after COVID, they noticed that they definitely had new anxiety they never had, or they already had it, but it got worse after the infection. And we hear that very often. And other common symptoms are myalgias, like pain in the muscles, or people lose their sense of taste and smell, never comes back, or they develop parosmias, meaning things smell badly, or they cannot enjoy foods because they taste horrible. Those are common. Ringing in your ears, blurry vision, a lot of pain and neuropathy, like feeling like pins and needle, and hands and feet is also commonly described. So this variety of symptoms that affect the nervous system in different ways. But the most common one, it's definitely brain fog. That's what we hear about the most.
It's incredibly common, as you mentioned. How debilitating actually can it be? I mean, Are these people working? Are they able to work, or they can't work anymore? Is this really disabling? And if so, how long does this last? Do they get better on their own, or is it chronic?
We actually have tried to look into that. And one of the earlier publications that Dr. Koratnik and colleagues had once the clinic started was trying to characterize the patients that were never hospitalized that developed long COVID, and they tried to see how disabling it was. They actually found that about 48% of those patients had to take some more than 10 days out of work. It definitely affects the workforce. Very commonly, people have to take leaves. They cannot go back to work, that during disability. Up to 48% that we saw in our research took more than 10 days off of work. So we have young population that are like in their prime of the productive life that now have this potentially disabling cognitive symptoms that are not allowing them to work very well. They also have a little fatigue that also interferes with their daily routine, daily lifestyle. We don't really know how long it's going to last. We have tried to look into that as well. There's actually a paper that was published looking at the evolution of symptoms. And there was a follow-up of the first patients that were seen in the clinic, and the median time in which they were seen was about 9 months later. And really the only symptoms that got significantly better were the loss of sense of taste and smell. Otherwise, patients continue to have the brain fog sensation, the fatigue, and the other things that I just mentioned. So it seems to be that the symptoms persist over time. However, we are not able to say how long it's going to last for each person. There's people that get better in 3 months, and there's people that it's been 2 years and they're still affected. And we have not been able to predict who is going to be the one that gets better quicker and who's going to be the one that it takes them longer. But we do see as a whole that people tend to get better over time.
Well, that's encouraging.
Yeah. In this study specifically, we saw that the first visit, people felt that they were about 65% back to baseline. And the follow-up visit, they felt that they were about 75% back to baseline, and this was statistically significant. So overall, there is a trend to improvement, but there is definitely the presence of persistent symptoms over time. And everybody just follows their own trajectory. Everybody goes at their own pace.
Have you been able to identify what puts somebody at risk for long COVID? Is it gender-based, age-based, severity of disease, no vaccine? What are some of the risk factors?
Yeah, no, that's a great question. So we have been able to identify some things. For example, we have been able to identify that people that have a history of autoimmune conditions, they are more likely to develop long COVID. That we identified. And also, women are more likely to develop long COVID. In all of the studies that we have done, long COVID is always more prevalent in women as compared to men. And this has led us to think, as we know, that women have a higher tendency to develop autoimmune diseases. And we know that people that have autoimmune diseases at baseline have a higher likelihood of developing long COVID. We think that long COVID likely represents some sort of autoimmune dysregulation or some of autoimmune condition. And we think that that is one of the risks will be being a woman having an autoimmune condition at baseline. We also recently, this was one of my fellowship projects that just recently got accepted in the Annals of Neurology. We wanted to compare being hospitalized and not being hospitalized. Like somebody that had COVID that was severe enough that had to be in the hospital, and somebody that didn't have severe COVID. But both groups developed long COVID. We wanted to compare them and see what they had in common or were they different. We found that the neurological symptoms overall were similar, like the brain fog, and overall things were about the same between the two groups. The exception were that patients that were not hospitalized had more muscle pain, like more myalgias, and also more loss of sense of taste and smell. But otherwise, the brain fog was similar between the two groups. However, we did find, which was interesting, is that the patients that were in the hospital, because once we see the patients in our clinic, we do a cognitive test. The patient perceives their memory problems as brain fog, but we want to be able to determine exactly what the problem is. So we do a test that is called the NIH Toolbox, in which we test different aspects of cognition, attention, executive function, working memory, and then once we're able to identify what the problem is, and if the patient scores below what is expected out of them, we send them to cognitive rehab. We have a cognitive rehab program at Schiller Ryan. So what we found is that those patients that were hospitalized had significant decrease in cognition, executive function, attention, working memory. And this was statistically significant. And the patients that were not hospitalized only had decreased attention, not the other domains. So it looks like the patterns of cognitive dysfunction are different between those two groups, which lets us think that the etiology of long COVID is different for those two groups. They're not apples and apples, they're different. That's what we're working on now, trying to see we think that perhaps the patients that was in the hospital with acute illness perhaps had some sort of neurological damage that leads to a specific pattern of cognitive deterioration that the non-hospitalized patient didn't have. So that is what we're working on right now as well.
What do we know about long COVID in low and middle income countries? I mean, most of the reports I've seen, they're all from the US or Europe.
That is a great question. And that's what has inspired us to expand our research to other middle income and low income countries. In Nigeria, there's a group of Nigerian collaborators in Lagos, Nigeria. They're incredibly proactive, incredibly hardworking, and they're also launching a neuro-COVID clinic. They already have preliminary data that we shared at Global Health Day with you guys. And because they didn't have any information. First of all, the real burden of just COVID infection itself in Nigeria is not accurately known because many patients didn't really get tested or went to the hospital. And they suspect that the real burden of COVID and then long COVID is higher than what we actually even think. What they have found in their studies, they have done great work and research. They've identified around 1,300 patients that had COVID. They called them, see them in the clinic. And of those, a small amount reported having persistent neurological symptoms. It wasn't 30% like we have heard here in the US. For them, the number went down to only 91 patients, which was like 6.7%. And then they saw that they also tried to compare those that were in the hospital, those that were not in the hospital. And they saw that both groups had persistent neurological symptoms. And they found very similar symptoms to what we have found here in the US. Like about 60% of their patients reported having brain fog, fatigue, headaches were common for them too. And something that is interesting is that the rates of depression and anxiety were much lower than what we had here in the US. But they suspect that this is more due to the cultural perception that you don't really talk about depression or anxiety, or you don't really report having depression or anxiety. So they suspect that this is much higher than what we're seeing. So basically, this preliminary data is showing us that long COVID does exist in Nigeria. They have cognitive symptoms too, like people have here in the US. And the extent of how much it affects them, it's something that we still need to investigate. But we have been able to determine that it does exist in Nigeria too. We are interested in knowing how much does it affect South Americans. And that's where we decided to launch this project in Colombia too, which is where I'm from originally. Because we don't know really what are the numbers, like are people being affected by neurological sequelae of COVID-19 in Colombia. So that inspired us to do this. And now we're finally at the point that we're ready to start recruiting patients. Upon talking, there's been a lot of conversations with neurologists and everybody. And they told us that they definitely have very frequent consultations from patients saying, after I had COVID, my memory is not the same. After I had COVID, I
Hmm.
cannot concentrate. After I had COVID, my performance at work is not the same. So it sounds like it's present there, but we still don't have numbers to know how prevalent it is and how disabling it is.
How did you jump from Nigeria to Colombia?
The Institute of Global Health in Northwestern is funding not only my fellowship and the second year, but also I was given a grant to start a project. Since I am from Colombia and I had my medical school, I thought, well, maybe we can do it there. We started talking with them since January of 2022. We have had to overcome several obstacles to be able to establish the collaboration. It hasn't been a very straightforward thing to do, like definitely has taken a lot of conversation. I think that it's been interesting learning how every country has their own limitations. Like even though I like the institution that we're working on, which is my medical school, I know is a extremely serious, excellent institution, but there's regulations that they need to pass. Like they, for example, needed a lot of forms and extra things that we were not expecting. And I'm asking, why do we need all this? And they're telling me, well, it's because there's such high corruption in the country that we're highly regulated. And so we need to take all these extra steps because there's just the regulations that they have that we don't have those kind of things in the United States. So that has been interesting to navigate through. But fortunately, now we're at a place that we're ready to start recruiting patients. But that's what led us to Colombia because that's where I'm from. And the Institute of Global Health funded the project there. Nigeria, Dr. Koralnik had already established the collaboration before I started my fellowship. He already had contacted the people in Lagos. He had already started that before I arrived. And you'll be interested in knowing this, but the next fellow who's coming, the next neuro-immunology fellow, she's going to be here in July. She was listening to one of our talks and she's saying, maybe we can start one in Bangladesh. She has contacts in Bangladesh and she's interested
Why
in
not?
starting a clinic there. So maybe we will have another continent that can join our projects.
What kind of cultural barriers did you run into?
I think that the biggest one has been the population will not seek for help unless, like, for something that is not perceived as disabling. Like, the population will
Hmm.
not seek for, like, they will not go to a doctor, a hospital for chronic fatigue or feeling like they cannot concentrate because that is not, unless you're seriously dying from something, you're not going to go ask for
Hmm.
help. And that leads to under detection of the problem and that really people are suffering in silence without really getting help. And I think that that's
Hmm.
similar in Colombia too, honestly, because I went to visit home just last summer and I was talking with my uncle who was driving me to all these places. And he was like, after I had COVID, yeah, kind of not as sharp, but that's just life. And, it's just a very different perception of
Hmm.
when I go look for help as what it is here
Hmm.
in higher income countries. I think that it's a shame because everybody should get access to help and everybody should, especially for something that can be potentially disabling or interrupt with your performance. So I think that has been the biggest cultural barrier and just people admitting to feeling anxious or depressed. Our collaborators will tell us that in Nigeria, like you will really have to dig really hard asking a patient about mental health for them to acknowledge that they do have depression and anxiety, which is also different to what the culture is in the US as well.
Gina, you're almost at the end of your fellowship here after 2 years.
Yeah.
What's next for you?
Well, I'm gonna have a baby.
Congratulations, by the way.
Thank you, thank
Yeah.
you. I'm gonna start my first official job, faculty position in July, at the Medical University of South Carolina, MUSC in Charleston, South Carolina. I definitely plan to keep global health as part of my career. The Medical University of South Carolina also has a global health institute that I plan to be a part of. I already contacted them. I plan to continue to be involved with Northwestern, with Dr. Koralnik. We plan to continue to collaborate. We started this project in Colombia, and I definitely want to continue to be a part of it, even if I'm in a different institution. I feel like once we have started one project, we're opening doors for other projects in the future. So I'm sure that we'll be able to collaborate with Colombia, Nigeria, and any other places in the future with other projects as well. So I'm really excited for the future.
Any advice you could give for students, both U.S. and non-U.S., who want to take on global health?
I think that my advice will be that just having an idea and finding people that share the passion that you have for your idea, it's really the most important thing. There's going to be obstacles, as I said. The Columbia project is taking us time to go to be at the place that we're at today, but you just keep finding people that share the interest that you have, and people will try. In places like Colombia or Africa that don't have access to such support in their regular lives, they're very interested. I mean, they'll try to overcome the obstacles. Like the obstacles that we went through, they were the ones that were trying to find the solutions. Like they're very resourceful. So I think it's just having the idea and the passion, and just keep insisting, and things will happen. Just having the support of institutes like this one, things can really happen.
Gina, thank you very much.
Thank you very much. Thank you for having me, and thank you for all your support.
Follow us on Apple Podcasts or wherever you listen to podcasts to hear the latest episodes, and join our community that is dedicated to making a lasting positive impact on global health.